So I want to invite someone special to the stage. So Dr. Naga Chalasani is a few things. He's the division chair for the gastroenterology and hepatology department at Indiana University. He is a well-founded investigator. He's also my mentor. So thank you, Dr. Chalasani, for being present.
Thank you. Rather speak.
Use this one. Sorry.
All right. Congratulations, Craig. This is wonderful. And I want to thank the patients and families who have come from multiple states. And I was here as well for the first course, and this has grown, and also more partners here. I'm very proud of what Craig has done. Just to give you I've mentored Craig for about 10 years or so. When he was a medical student, he reached out to me and he said he wanted to do research, and I said, fine. He comes in flip-flops and shorts. Fast forward 10 years later, what a design suit. Giving a TED talk, really impressive. Really, though, it's great. And I know I've seen his office is next to mine, and he has spent many months prepping for this, a lot of conference calls and a lot of late hours. I think we've put together a wonderful seminar here. Also, I want to thank Sharon and Ruth and other members of the board of AIHA. Couldn't be there last night. Seems like this association is coming along very nicely, and I think it's long overdue. I think PSC for Cures and others have been there, so this is a late comer to the field, but I think this is one that's going to serve the patients very well. I want to take a moment to thank some of the guests we have. We have Dr. Lindsay King from Duke, and Michelle from San Francisco, and also Syed Mohammed from pediatric hepatologist who has come from Northwestern. I think I missed his talk. And it's really phenomenal that they're taking their time to come spend the weekend here. And the weekends are precious. And once again, I want to congratulate you, the association, and Craig for putting a wonderful course together. And I also want to introduce one of my heroes, Dr. Bruce Bacon, who kindly agreed to spend his Saturday here. Dr. Bacon, I think many of you may know, may not. Since you may be in different parts of the country. Dr. Bacon is a very respected and a highly successful and treated thousands of patients in his career. He's a very distinguished hepatologist. When I finished my fellowship, some 20 years ago, he was a luminary at the time, and I actually wrote to him asking if I could join his group, if he had a job for me. And I think he sent a nice note saying, no, I don't have a job for you. Worked out okay, I think. I haven't done badly here at Indiana, but he's been a great supporter. And Dr. Bacon led the GI division at St. Louis University for 20 years or so. Under his leadership, it became one of the top research and patient care GI divisions in Midwest and nationally. And Dr. Bacon himself is a highly successful researcher. He really pioneered the field of hemochromatosis, which is iron overload disorder, and then also has done fundamental work in other, like fatty liver disease, autoimmune hepatitis, and he served as the president of our liver society, and then also is currently, that was in 2004. He received the Distinguished Achievement Award in 2010 by ASLD, really big deal for us, really big deal. And since 2013, he's been serving as the ASLD Foundation president, which is the ASLD arm that gives out millions of dollars for research. And I've seen some of the grantees more recently, certainly focused on autoimmune hepatitis as well. I mean, a really very thankful, and I think it is our good fortune to have Dr. Bacon visit us today, and a round of applause for Dr. Bacon.
I'm going to have to go back and see if I can find that letter. Thank you very much for those kind words, and it's a pleasure to be here with you today. When Naga asked me, I didn't wait very long, a couple of minutes maybe, to say, yeah, I'd love to. This would be fun. This is a little different. This is in our neighborhood. I think Indianapolis and St. Louis are sort of sister cities, and it's a pleasure to be here with all of you. And I know some of my patients are here, and thank you for coming. So it's a great organization that Craig has developed, and he asked me to speak really on something on autoimmune hepatitis. He didn't really push me one way or the other. And so what I've put together for you today is some comments about autoimmune hepatitis, a little bit about primary biliary cholangitis, and a little bit about what we call overlap syndromes, where patients have both primary biliary cholangitis and autoimmune hepatitis, and what that means, how that presents, and what we do for it. I remind you that these disease states are, people ask me, when you're seeing someone early on, and I'm sure you thought of it as well when you, those of you who have this disorder, you thought, well, do I have to take these medicines for the rest of my life? And I always say, well, it's indefinite. And then I say, that's doctor talk for the rest of your life. Because these are diseases that we manage. They're not diseases that we cure. So we have to stick with it, and it's important for there to be good working relationships between patients and doctors in order to get successful outcomes for these diseases that we have for such a long time. So what we'll do today is talk a little bit about autoimmune hepatitis, a little bit about PBC, and a little bit about overlap syndromes. And our aims are to increase knowledge about typical autoimmune hepatitis and to increase knowledge about typical primary biliary cholangitis. And I know PBC is a little different. It's not part of autoimmune hepatitis, but we frequently see these patients with these overlap syndromes, and it's important to know about this. And I would say AIH and PBC are, along with PSC, primary sclerosing cholangitis, are the immune-mediated diseases that we see in hepatology. And then, to understand overlap syndrome. So disclosures, those of us who work on a number of these different disorders and frequently who work in viral hepatitis interact with industry. So those are the disclosures. Those are things that I've done. So suffice it to say, autoimmune hepatitis, and you've heard a little bit about this already from Craig, predominantly affects hepatocytes, or the liver cells, whereas PBC, primary biliary cholangitis, predominantly affects cells called cholangiocytes, or the bile duct cells. And sometimes we have all of one or the other. Sometimes we have both. And sometimes what's intrigued me over the last several years, I've been at St. Louis University for a long time, so I've been able to follow patients sequentially for a long time. Sometimes we see patients who start out with pure one or the other and add the other or the one. And I'm going to give you some examples of that. I think you only realize that occurs when you've followed a large number of patients for a long period of time. So autoimmune hepatitis, I'm going to go through these kind of quickly because many of you know this, but I understand it's a pretty diverse audience. Some people who are just brand new to this disorder and some who could write chapters about it. Patients are mostly women. 75% age of onset is bimodal. There's many young individuals who present with AIH, and then those in their later years. Characteristic clinical presentation shown here. Patients can have anorexia, fatigue. You heard about the discussion of fatigue just a few minutes ago, and it's usually in a young woman. There's a subset that has what we call fulminant hepatic failure, where patients present with really, really severe liver disease with liver failure and have to have a transplant. That doesn't happen very often, but it does happen. And then there's patients that have the disease state that is very well established at the time they present. And what you realize with those patients is that they've had it for a long time. And I have patients that I see in their 60s or 70s who have cirrhosis, and their liver enzymes aren't elevated anymore. They come because of cirrhosis, and you find some of the autoantibodies are there, and you get a history of, well, they had some liver enzymes abnormal 30 years ago, but nobody did anything about it back then. And you realize that those are patients that have had indolent autoimmune hepatitis, or PBC, it happens there as well, over many, many years, and they present with what I call burnt-out disease, where they already have cirrhosis and they really don't have as much active inflammation anymore at this time. There are biochemical markers that we look at. We talked a little bit about AST and ALT. John talked about that earlier. They're typically elevated 5 to 10-fold, so they can be quite elevated. But you can have a minimal elevation of alkaline phosphatase or bilirubin in autoimmune hepatitis, and that's a little different in PBC. This is just an example of light microscopy, and you see all of these purple cells here on this low power view in a portal area are inflammatory cells that are there and are the hallmark of autoimmune hepatitis. It's a rare disease, as we've already discussed, 50 to 200 per million in Europe and the U.S. And the comment was talked about earlier in looking at pathogenesis, the loss of self-tolerance. Oh, if we could tolerate ourselves. Well, anyway, yeah, we all have to practice self-tolerance, but sometimes it can be pathological. There are circulating autoantibodies. There's often thought to be a triggering event. There's something that happened. Patients are exposed to some, maybe to a virus, maybe to a toxin. You wonder about all the things that are in our environment. I mean, there's certainly features that lead to that. The thinking there is a protein gets attached to an hepatocyte, and that leads to the immune system not recognizing that as normal and trying to destroy it, and that damages those hepatocytes, and we have what we call autoimmune hepatitis. And then the genetic component, and this was discussed briefly, with an HLA connection. What about autoantibodies? So anti-nuclear antibodies are positive in high titer, typically in patients with autoimmune hepatitis, and also anti-smooth muscle antibodies. There's kidney microsomal antibodies that are identified as well. This is typically in what's called type 2 autoimmune hepatitis and is more commonly seen in children and more commonly in Europe. There's anti-SLA, you heard about that a little bit earlier, but there's some other ones that are less frequently found as well. I oftentimes get ANCA in patients that are ANA negative or anti-smooth muscle negative and find ANCA strongly positive and have and then treat those patients as typical autoimmune hepatitis, and it works. So these are some diagnostic criteria, and this is one of those scoring charts like Craig showed. Female patients get extra credit because we see this disease more commonly in women. If the ratio of alkaline phosphatase to ALT is lower, then they get a point for that. Their serum globulins are elevated. Their ANA, smooth muscle antibody, or LKM, those are positive. But if they have an AMA, that suggests that maybe they have PBC and not AIH, so they get a negative point for that. If they have markers of viral hepatitis, they get some negative points for that. If they have other etiologies like they drink or they've got fatty liver disease or other things, they get a little negative mark for that. The histology is important, and then other autoantibodies. And you put that together, and that's the scoring system that Dr. Lammert was showing. There are some extrahepatic manifestations, which you've heard about as well: thyroiditis, ulcerative colitis, and arthritis. Those are frequent. These are some of the less frequent extrahepatic manifestations. Usually patients don't present with these, although there are some patients with thyroiditis who have, and I guess ulcerative colitis as well. But usually people present with the liver disease and then are found to have these other disorders. Treatment is fairly standard at this time for most patients. It's usually prednisone. Some people use prednisolone and some use budesonide, which are other prednisone-like agents, or corticosteroids. I always tell patients, you tell patients that you want to put them on prednisone in this look of panic and fear and agony and disagreement, and I don't want that, and I hate prednisone, and I knew someone who had prednisone and they gained a lot of weight, and I don't want to do that, and nobody likes prednisone, and I recognize that. So I try to explain that prednisone induces a response, and Imuran, or azathioprine, maintains a response. So to let people know that we usually don't have to keep them on prednisone for long periods of time, and usually I would say I have patients on prednisone only for maybe 2 or 3 months at the max. I try to minimize it quite a bit and get people on to medicines that are a little bit easier to take. The other thing I say is, patients say, well, prednisone makes you fat. And I said, no, prednisone doesn't make you fat. And then depending on how well I know the patient, I have to pick my words carefully here. I say, eating too much makes you fat. What prednisone does is it stimulates your appetite. But prednisone doesn't have some magical effect that makes you overweight. It just makes you hungry. And so a lot of times if you're armed with that information, you can fight back that stimulus and not eat as much and not gain weight on prednisone. And then other agents that we use are mycophenolate mofetil or Cellcept, cyclosporin, methotrexate. Most hepatologists aren't too keen to use methotrexate because it can be a hepatotoxin itself. So we try to stay away from that, but it's been used. And the duration of treatment I put with a question mark because it's, as I said, it's usually lifelong. And these are the ways in which you can use prednisone and Imuran. This is a schematic illustration here. Some people start out with prednisone, 30, 40, 60 milligrams per day, depending on the severity of the disease. And then they get things under control, liver enzymes are normal, and then they gradually taper the prednisone. Remember, prednisone has to be tapered. And they do that while Imuran or azathioprine is exerting its influence. So you start the full dose of azathioprine when you start to taper the prednisone. Others start both at the same time and just keep the Imuran along and then taper the prednisone. I like to do it this way, where I put patients on prednisone first and then taper, because I want to make sure they've had a response to treatment and that I know what has led them to have the response to treatment, which drug. When you put both of them together, you don't know that, but a lot of people do this. It can be done both ways. Liver transplantation is rarely needed in autoimmune hepatitis, but it is done. And anti-nuclear antibodies can persist, but the titer is usually down, and autoimmune hepatitis, unfortunately, can recur after transplantation. But we don't need to go to transplantation in lots of our autoimmune patients. Now, I step over to primary biliary cholangitis, and some of this will be new to you, that those of you without it, it too is fairly rare, 1 to 200 patients per million. Again, a strong female preponderance. Median age at diagnosis is in middle years, and it can be familial. It's not considered inherited per se, but there are cohorts of cousins or patients that have PBC. And then it underwent a name change. It used to be called primary biliary cirrhosis, and now it's called primary biliary cholangitis, because this is more reflective of the disease state. And this name change occurred a couple years ago. And there's a whole bunch of different things that are associated with primary biliary cirrhosis. I'm not going to go over them all. I'm going to talk a little bit about overlap syndrome, and the typical PBC patient is one who has anti-mitochondrial antibodies. It's present usually in about 90% of patients. It's an antigen of a protein on the intermitochondrial membrane. And there's a little bit of biochemistry here, which I won't go through. Some people have questioned whether AMA plays a role in the pathogenesis of PBC. The arguments for are that cholangiocytes express this particular protein, and autologous T cells can be reactive against these cholangiocytes. What argues against it, and what is most important to me arguing against it, is that it's not present in all patients. You have many patients that have what we call AMA negative PBC. And the titers of the AMA don't correlate with disease activity. So the jury's still out on this. This is just an example of progressive liver injury that occurs in PBC, a bile duct injury and loss of bile ducts. This is a bile duct here, and this is a damaged bile duct. That in turn causes cholestasis, where there's a backup of bile. It doesn't flow through the liver normally. That can cause necrosis and fibrosis or scar tissue, ultimately cirrhosis, and ultimately liver failure, and portal hypertension can occur. Like autoimmune hepatitis, fatigue is the most common presenting symptom. And like autoimmune hepatitis, we don't have good treatments for the fatigue that occurs with these diseases. Another symptom that is quite bothersome in PBC is pruritus, or itching, more so than in autoimmune hepatitis, and sometimes just absolutely miserable for patients. Dark urine if they're jaundiced, light stools the same, and easy bruising with coagulation factors abnormal. Diagnostic algorithm is here. Most patients present with an elevated alkaline phosphatase. They get an ultrasound. If their bile ducts are normal, if their bile ducts are abnormal, you try and figure out why. If their bile ducts are normal, you would have an AMA, and if it's negative, you may need a liver biopsy or a test of the bile ducts with a scope called an ERCP. If their AMA is positive, liver biopsy is now optional, and it's not automatic that liver biopsy be done to make a diagnosis of PBC. I still do a liver biopsy in anybody that I think has newly diagnosed PBC, because I want to really be certain that I know not only that the disease is correct, but that I know the severity of the disease. So diagnosis is biochemical evidence of cholestasis, elevated alkaline phosphatase typically, but they have an increased level of IgM. GGT is another enzyme that's elevated along with alk-phos, as is 5' nucleotidase. Have AMA assay, and then a liver biopsy that shows what is called by the pathologist sometimes non-suppurative destructive cholangitis. That's a mouthful. Histology, again, the pattern of liver cell injury is a bile duct abnormalities, and there can be what are called granulomas that are characteristically seen in PBC. So the natural history, it develops complications over decades. This is a very long standing disease. And multiple studies have defined prognostic factors that predict survival. Liver cancer is relatively rare in PBC. And this just shows the natural history of these are older studies. And this is, you see here, a control population and patients who had PBC and generally did not have symptoms. Their survival decreased after 10 to 12 years of the disease, even though they felt fairly well compared to a control population. So it can be a problem. Now, I wouldn't agree with this natural history today because we have much better ways of treatments for these patients, and they do better longer. And this just looks at natural history again by different mechanisms, and seeing that when you present with more severe disease, your survival is worse faster. No surprise there. There are treatments. There are a whole bunch of treatments that have been tried in PBC. The only one that works is ursodeoxycholic acid, or UDCA. But just recently, about 6 months ago, a new agent was introduced called obeticholic acid, which clearly works in a subset of PBC patients. But several other things that have been tried don't work. So what do we see with therapy? We see liver enzymes improve. Our goal is to get alkaline phosphatase to normal. Symptoms improve. Mayo risk score improve. Transplant-free survival and survival in general are extended for longer periods of time. What about liver transplantation for PBC? Well, it's end-stage liver disease. The patients do very well. AMA usually remains positive, and PBC may recur like autoimmune hepatitis may reoccur. Now, I wanted to talk just a little bit about these overlap syndromes because these are a little bit different, and some of you may have heard this, some of you may not, but maybe you should know about it. So there are some patients who begin as what I call pure autoimmune hepatitis. It's very straightforward. And they acquire PBC. Some patients begin as pure PBC and they acquire autoimmune hepatitis. And occasionally you'll see a patient who presents with evidence of both diseases at the same time. So we've had some interest in overlap syndrome for a while. I have about quite a number of patients that are diagnosed with overlap syndrome. And we put together, we took information from, in our practice, of 105 patients with autoimmune hepatitis, 102 with PBC, and 65 who had overlap syndrome. And we developed a scoring system, like that scoring system that Craig showed you a little bit earlier, and I'll show you what ours is. And we found that a score higher than 21, there was a very high likelihood of overlap syndrome, and less than 19, it was unlikely to be overlap syndrome when you had patients with this disease entity. And these were the scoring and the relative points that you would get. So as I said, if they were greater than 21, they definitely had overlap. If they were 19 to 20 probable and less than 20, they didn't have overlap syndrome. So this is a way to try and objectify something that's been fairly subjective so far, and that is diagnosis of overlap syndrome. I'm going to finish up with a few case histories, little vignettes of these disorders. So this first one is a 45-year-old lady who presents with persistently elevated ALT, AST. She has a normal alkaline phosphatase and a normal bilirubin. She had fatigue and joint aches as main symptoms. So she had an anti-nuclear antibody that was strongly positive and an anti-smooth muscle antibody that was strongly positive. Her AMA was negative. Her ALT was elevated at 175. Her alkaline phosphatase was normal, and her AST was slightly elevated. so that sounds like autoimmune hepatitis. And the liver biopsy was done, was characteristic of autoimmune hepatitis. She was treated with 30 milligrams of prednisone for 6 weeks, tapered, Imuran was added, and everything was going along okay. Her liver enzymes were normal at 4 weeks on treatment. She was feeling well, and she was managed on azathioprine then with 3 monthly or 6 monthly visits to check labs. You know what those visits are like. Do you need a refill on your medicine? Are you feeling okay? Your laboratory tests are okay. I'll see you in 6 months, right? Those are those easy follow-ups. And I have patients that say, why do I need to come back? You never do anything different. And I remind people of this kind of patient. So I would say about once a month out of my cohort of PBC patients and autoimmune hepatitis patients, we find something that's changed. And that's why we see people back in follow-up. So 5 years later, so she said, let's see, every 6 months for 5 years, she comes for routine follow-up. And now her alkaline phosphatase is elevated up to 280, and her bilirubin's up to 1.8. And the questions that come to us at that time are, well, does the patient need a liver biopsy? Why does she have cholestatic liver enzyme abnormalities now? Does she need a liver biopsy? Can you say, well, she's developed overlap because it's like what you see with PBC, and just empirically treat? And I've gotten more comfortable with empiric treatment as I've seen more of these patients. So we choose empiric treatment with ursodeoxycholic acid, which is used for PBC, and follow up then a couple months later. Everything is normal. And this is now a patient who I would categorize as saying has overlap syndrome with both autoimmune hepatitis and primary biliary cholangitis, and will stay on Imuran and urso long term. So this is patient example number 2. Another 45-year-old female. I'm not picking on 45-year-old females, but that's what happens. Complains of pruritus and has an elevated alkaline phosphatase, fatigue and joint aches, same as the other one. And the AMA was very strongly positive. Anti-smooth muscle antibody negative, ANA slightly positive, ALT normal, AST normal, but alkaline phosphatase quite elevated. Liver biopsy characteristic for PBC, treated with urso at 600 milligrams twice a day. So at 8 weeks, her alkaline phosphatase is normal. She's feeling well with no pruritus. 5 years later, her liver enzymes are elevated up to 130. And it's just the same questions, but from a different direction. Do you do a liver biopsy, or do you treat that patient empirically? Again, in this situation, empiric treatment was selected. We add prednisone, taper, and end up with Imuran for, and then that patient has overlap of primary biliary cholangitis with autoimmune hepatitis, and is followed treating both diseases long term. And finally, this is patient example number 3, another 45-year-old female with fatigue and pruritus. This one has a higher ALT of 550 with an AST of 400, but also has an elevated alkaline phosphatase. ANA is positive, anti-smooth muscle antibodies positive. AMA was positive to it, but it didn't get in there. Liver biopsy was done, features of both PBC and AIH, treated with urso alone for starters for at least 6 months. And many of these patients can be managed just on ursodeoxycholic acid alone. You don't have to use immunosuppressive therapy alone. There's been, so some of these patients resolve with urso alone. Some, though, after that period of time, haven't resolved and will require prednisone and Imuran. And so this is a schematic of this continuum here of classical autoimmune hepatitis on the left-hand side here that can extend over to the overlaps that are here in the middle, or there are patients that start out with classical PBC, and they can develop overlap. My comment to the fellows is that when we have a disease state that we're taking care of in whatever organ system, whatever, that when you have a disease state that you call overlap syndrome, it means it's purely descriptive, and it means we really don't know what we're doing. I mean, we do, but when I'm being facetious. But when we resort to calling something overlap syndrome, we really don't understand the pathophysiology very well. Eventually, we will. But these patients occur. You can see them, as I said, you can see them start out with autoimmune and develop PBC and have both. You can see them start out with PBC and develop autoimmune and have both. You can see them who already have both at the time that they present. So last slide, patients, these various groups of patients can be complicated, but they're usually very gratifying to treat. I find my autoimmune patients and my PBC patients some of the people I enjoy interacting with the most, and usually treatment is well tolerated and successful. Thank you very much.